everyone, let's see cleidocranial dysplasia. Its other name is cleidocranial dysostosis. It has dental as well as clavicular abnormalities. There is generalized bone disorder which is caused due to mutation in RUNX2 gene on the chromosome 6p21. Now let's see more about this RUNX2 gene. There is mutation in this gene. So it will cause disruption in the normal features like osteoblastic differentiation, chondrocyte maturation and appropriate bone formation. There is also distinct dental abnormalities. Initially, only it involves membranous bones like clavicle, skull and flat bones. Clinical features. Bone defects chiefly affect clavicle and skull. Various other skeletal abnormalities are also there, but mainly clavicle and skull are affected. Clavicle may become hypoplastic or discontinuous or may be completely absent in 10% cases. This clavicle abnormality may be unilateral or bilateral. The patient's neck appears long, shoulders are narrow and marked drooping. Clavicular abnormality is there, so there will be unusual hypermobility because there is no collarbone, so patient will be able to approximate shoulders in most cases. Like here we have shown partly missing collarbone. So we have shown here discontinuous collarbone. So it can be on one side, that is unilateral, or on both sides, then it will be bilateral. Other features can be present, which like short stature, enlarged skull, brachycephaly, pronounced frontal and parietal bossing, ocular hypertelorism, broad nose. So broad nose with a depressed bridge of nose. Let's see the radiographic features. The radiographic features, first of all, skull. The skull sutures and fontanelles show delayed closure. Here we have shown fontanelle and it has not closed. So it may show delayed closure or it may not close throughout the life. There is abnormal development of temporal bone and eustachian tube, and due to this there may be hearing loss and recurrent ear infection. Jaw and dental manifestations are distinctive and they help in initial diagnosis. Let's see dental manifestations. First, there will be narrow and high arched palate. There can be prevalence of cleft palate. There will be over-retained deciduous teeth. So these 2 points are important. There will be over-retained deciduous teeth and there is delayed or complete failure of eruption of permanent tooth. So if there is failure of eruption of permanent tooth, we will be able to see unerupted permanent tooth on the dental radiograph. So on the dental radiograph, numerous unerupted permanent and supernumerary teeth can be seen. And these teeth often have distorted crown and root shapes. As the patient ages, the short lower face height, there is a short lower face height, acute gonial angle, anterior inclination of mandible and mandibular prognathism. So there is mandibular prognathism. Why? Because there is inadequate vertical growth of maxilla. So maxilla is not able to grow properly. So that's why there is mandibular prognathism. The mandible is not able to grow. There is no inadequate vertical growth of mandible. So there will be mandibular prognathism and anterior inclination of mandible. And there is, as we saw, there is lack or delay of permanent tooth eruption. There will be hypoplastic alveolar ridge. Now let's see the treatment. Most patients function well in everyday life, but there are dental problems which are difficult to address. Preferred treatment is removal of primary teeth because they are over retained and supernumerary tooth, and then we will expose and orthodontically we will extrude the permanent teeth. Orthognathic surgery can be done after jaw completion because there is mandibular prognathism, anterior inclination of mandible, inadequate vertical growth of maxilla. So for that, orthognathic surgery after jaw completion, that is after growth completion, is preferred. Additionally, full mouth extractions, auto-implantation of selected impacted teeth and then appropriate prosthesis is given. This was all. If you found this video helpful, do like and subscribe. Thank you.